Good afternoon. Thank you for joining us for today's webinar. This is Traumatic Brain Injury and Suicide, Assessment and Planning with an emphasis on veterans. This webinar is sponsored by the Rural Veterans Health Access Program and provided by the Alaska Area Health Education Centers. All participants will be on mute during the presentation. If you wish to ask a question, you can type it into the question box at any time, and there will be time for questions at the end. If you would like a copy of today's presentation, you can download it from the Handouts tab in the sidebar. Now, we're joined today by Susan Maley, Program Director for the Rural Veterans Health Access Program, and our presenter, Eric Boyer, from the UAA Center for Human Development, Alaska Training Cooperative. I'd like to turn it over now to Susan Maley.
Thank you, Pat. I want to give a brief explanation of the Rural Veterans Health Access Program and then turn this over to Eric, who we're very pleased to have join us. The Rural Veterans Health Access Program is part of the Health Planning Systems Development section in the Division of Public Health. We're funded by the Health Resource Service Administration Office of Rural Health Policy and their Office for Advancement of Telehealth. Our main focus is to have telehealth connectivity in remote southeast rural communities that have either no or limited healthcare services to provide telebehavioral health and in some locations primary care. These services are for veterans as the primary audience and also for community members as the secondary focus group, which means that veterans' family and friends can also have the services. We also provide training to behavioral and medical health professionals on the delivery of telehealth services to increase access for veterans and other rural community members. And so this has focused on traumatic brain injury, and this webinar is part of that series. TBI is one of our priorities for the group served veterans as the primary caregivers, as well as rural community members with TBI. And Eric will be covering some of the statistics for Alaska and how important this is, not only as a signature injury for returning vets from combat, but as veterans continue their lives, the risks of TBI in rural life in Alaska. So in our provision of TBI assessment and training, Eric's work now is going to be an important part of that, and this webinar will then be posted on our website, and all of you who have provided your contact information, once that is posted and it will be available to you within a month, we'll send you information. So this is just a photograph of one of the remote southeast Alaska communities. As of September, the Rural Veterans Health Access Project will be statewide, and so that's our new cycle, and we will look forward to providing both telebehavioral health and psychiatric assessments. And so my information is on this slide for anyone who wants any information about our current or planned services. So now I'm going to turn this over to Eric Boyer. Eric is one of the leaders in suicide prevention in Alaska and has worked closely with veterans and military organizations and is a senior trainer at the UAA Training Cooperative. And Eric, thank you so much for being with us today.
Well, thank you, Susan, and good afternoon, everybody. It's a pleasure to be here, and I wanted to thank Susan Maley in the Rural Health Veterans Access Program for having us here today to do this and really having an opportunity to bring this to the state. I also want to thank Pat Sammartino for having us here at the Alaska Area Health Education Center, providing a venue for us to get this out to folks and to be able to record it, to have for future looking and support with other colleagues that you guys have. So today we are going to look at some of the trends in traumatic brain injury and suicide in Alaska, kind of compare those, look at some numbers from the Department of Defense, and really look at some of the crossover of those symptoms, some of those warning signs that we're seeing, and having an opportunity to know how to get further training on assessment and to look at providing safety in those kind of opportunities. So kind of as you guys are listening and watching this webinar, some of the things I want you to think about as we go along and kind of some of the takeaways. There's been some recent research coming out just in the last year. There's a large research project done out of Toronto, Canada by Dr. Redelmeyer, and he did that with 3 colleagues from New York State, all medical doctors who've been looking at the prevalence of traumatic brain injury in a non-hospitalized research project. So these are all people who suffered mild to maybe moderate TBIs and were not hospitalized. And they looked at this large group, and what they realized is there was a 3-fold increase in the number of suicides in this group. And this is a really large research group. It was 235,000 patients that they looked at. Some of their takeaways from this project, obviously the increased risk for suicide, but what they found is many providers, and I would be the first, having come from working in an inpatient psychiatric setting, is we sometimes don't take traumatic brain injury, especially when we see mild, seriously, or really look at the impact of that. And I can tell you from my work over the last 8-9 years in suicide prevention and intervention work here in Alaska, is that is a current theme there as well, is many times we don't take those suicidal thoughts or gestures or somebody thinking about it seriously. So if you combine that with somebody who's suffered a mild traumatic brain injury or multiple injuries in their past, whether that's with the military or in the civilian life, it definitely increases the risk. And if we're not taking that stuff seriously, it really, I think, hampers our ability to get somebody help or for them to feel that there's help out there. And the reality is I've got really good numbers and research that have come out just in the last couple of years as well that support there is opportunities for support and help if somebody knows it's out there and they can get them to that. So we want to look at that as we go through this. So today we'll be looking at those numbers, look at how we can assess that risk, and then what are the primary means for getting somebody the help they need. I want you guys to look at the safety planning, kind of measure that if you're in the field with what you do already, just as a way to remind you or even to bolster some of those internal systems and processes you have. Some of the treatment considerations that have shown some effectiveness in working with somebody with a background of traumatic brain injury and suicidal thinking or attempts. And so let's jump right in, and we're going to get into some of the prevalence data. These first few slides will talk about suicide, what that looks like in Alaska. We'll also look nationally, but then we'll look at the rates of traumatic brain injury. So as you look at these two maps, on the left-hand side, that looks at the data rates for attempts, and on the right, it looks at completed deaths. Those are people that have actually followed through and died by their own hand. This study of numbers is put out by the state of Alaska, and it's over a 10-year period. You can see that in upper right, 2001 to 2010. So it's a pretty good block of data. What you see in both sides of the map, the number on top in each region is looking at attempts and deaths. Those are ones that we're looking at per 100,000. When they measure, how people die, they look at per 100,000 of population. That's just the way epidemiology looks at that. And then the smaller number under each of those that you see in parentheses are the actual number of people who either died by suicide or attempted. So when you look at that on the left, you see the interior right in the middle of the map of Alaska. You see 96.6. That's the number of attempts per 100,000. And then you see the actual raw data. over that 10-year period, there was over 1,000 people who attempted suicide. What you need to note also are these numbers are only ones that were reflected by those who needed hospitalization. Just think about the people that you maybe have come in contact who've had a brush with suicide. They've attempted but didn't require medical attention and they were okay, they survived it. Those would not be recorded here. So I think we need to take that into consideration. Also note, when you look at the state of Alaska on the left, higher percentages, higher number of the rates in North Alaska, Northwest, Southwest Alaska. On the right, when you look at number of people who actually died by suicide, the rate per 100,000 is the bigger number. So again, looking at the interior, 17.9 over the number of 188. Those are actually 188 people that actually died during that period of time. I think it's, we need to note when we look at those numbers, they are numbers. They don't save people's lives, but it gives us an idea of what is going on, what's happening, so we can be more strategic about how we set up prevention programs and intervention programs. When I look at those numbers, because I've been here in Alaska just a little over 26 years this month, I know some of the people in those numbers, and so they do have an impact, and we need to honor that. We need to be cognizant of that fact that those cause us all to reflect, and there is sadness, but also an opportunity for us to move forward to figure out how to prevent the next person being in that place. This gives us prevalence data for Alaska and compares it to the United States as a whole. When you look at all causes of death from cancer to other forms, heart disease, things like that, you see suicide rates 10th in the United States, and it's up higher in Alaska. It's a higher, it's rated 6th. So it lets us know that we have a higher rate, and we need to be aware and really kind of focus on some of our programs of health out in the community around that. One of the at-risk groups that we're looking at in this slide is 15 to 24, second in the United States for a cause of death, and first in Alaska. Keep that in mind as we look at prevalence data of TBI, because I think that age group will be one that we see at risk, whether it's current in military or a veteran or back in civilian life. So thinking about that, the third numbers there reflect our rate per 100,000. Again, you see 13.4 in the United States. Alaska's second in the nation for rate of suicide at 22.7. Remember those numbers, because when we look at TBI, we'll see similar high rates here in Alaska, and I think that really will bring to mind folks that are at risk when you start adding these things up. And it's not that we need to panic, but we definitely need to be aware so we can know how to support somebody and get them the help and resources. Again, that per 100,000 rate for the 15 to 24, you see those numbers reflected nationally, and in Alaska, it's a lot higher in Alaska. And then also the rate of suicide for males and females in Alaska, a lot higher rate, almost 4 to 1 in Alaska for men who die by suicide versus women. Now let's move to looking at a little bit of prevalence data around TBI. This is data that came out in the mid-2000, first decade, around 2006, Centers for Disease Control, looking at Alaskans living with the disability of TBI, looking at the number that are hospitalized, what follows from that in terms of disability, being aware that, of course, this data is older. Some of our data is not in the last few years for Alaskan TBI, and just so you know, that's something that I've partnered with Susan Maley from the state, and it's actually something that she has been working with several groups from the university and in the community to come together and look at how we can look at what's going on currently in Alaska, so we can really be in the know of who's at risk, how to get our services to them. And again, that's really important now that Susan let you guys know that the next 3 years she has this grant for this, which has been primarily in the Southeast but statewide now. So we really have an opportunity to move forward at a statewide level to really bring awareness and resources to those who have a TBI, and that suicide is one of those issues that really hampers our ability to help, especially with returning veterans in the field. Here's just a breakdown looking at males and females, and this again is from the Centers for Disease Control. And I think it's really important to note when we look at these numbers here, all those who receive, a blow to the head or are in a accident where they maybe even have whiplash, things like that, those aren't recorded here unless they go to the hospital. So it's really important to know that these numbers, you can see we're up a little higher in Alaska, especially for males, just a little higher nationally on TBIs, and then Alaska natives, American Indians, you see those numbers reflected there are even higher. Those are just showing you numbers that have been hospitalized. Now, if you guys remember that third slide, the one we just looked at on attempts in Alaska and completed suicides, here is a slide that was made looking at folks that were hospitalized with the TBI from 2007 to 2011. And notice the darker areas, those are going to be where they're higher prevalence per 100,000. Again, North Alaska, Northwest, Southwest, you see higher numbers in that Cordova region, Yakutat. Really important to know if you got a higher risk, higher prevalence of TBIs in these regions, also where our attempts and where our completions of suicide. So those are targeted areas that if we look at who our partners are, what our resources, bringing awareness and education about what we can do, super important in those regions. Those are regions, I've been to all of those. I know Susan has been traveling to some of those regions and will be here. We've been talking about that in the coming year. We know that that's an issue, and we are partnering and offering resources to communities, to schools, to tribal entities, to our veteran partners. So it's really important to know that this information brings awareness, but being able to look at what we can do. Presently on the Rural Veterans Health Access Program site that Susan oversees with the state of Alaska, you can find a webinar and a YouTube video that's already been presently done by Dr. Amy Murphy. And so here we're talking about assessing for suicide. If you've just gotten and learned about this training, you might be asking, oh, how about assessment for TBI? And you can go to that website. I would encourage all of you, if you haven't seen Dr. Murphy, she's a board-certified brain injury specialist, and she does a really good job in an hour's presentation giving you current information about assessment, diagnosis, and treatment of traumatic brain injury with an emphasis on mild. So I think that can be super helpful when you look at the tools that are out there for assessing for suicide, assessing for traumatic brain injury, because I think that will add to our ability as a state to really raise the level of our skills and prevention efforts to get folks the support they need once we recognize something's going on. And I say that because one of the, I think takeaways from Dr. Redelmeyer's study that I told you about from Canada is not only that we need to take it seriously, but when we assess properly and we find out about these injuries to ourselves, like a traumatic brain injury, mild traumatic brain injury, is to make sure that it's a part of our medical record. Once you've got that in your history, on down the road, it really helps the collaboration between you as a patient, your family, and the medical providers, behavioral health providers, to have a complete picture for getting the supports that are best needed to help somebody through a critical point in their life. So now let's look at the Department of Defense numbers for traumatic brain injury. This is the Department of Defense has done 15 years worth of looking at the numbers of suicide, and they started this in 2000. They recognize the, through our efforts around the world in the theater of war, that blast injuries, vehicle accidents, falls, all the things that happen that cause brain injuries from mild to severe. We need to be aware of that. We need to, again, if it's diagnosed and we're getting people the help, then it's a part of their medical record. And if you look at that in 2000, it was just over 10,000. You see a peak in 2011, upwards of like 33,000, downward trend now as we've pulled out of some of those areas of war around the world. But 2015, still having 23,000 confirmed TBI. So if you look at that period of time, 334,000 diagnoses of TBI, that allows us to be aware of, you know, the numbers, folks coming back, so that our providers, whether they're military-based or in the community-based, aware of these numbers so they can be asking the questions and being prepared to provide an assessment.
We have one question from a participant. Do these numbers take into account the number of tourists and out-of-state workers that are here during the seasonal work times?
Yes, so if somebody does not live or reside in the state of Alaska and they receive an injury and they are hospitalized and assessed for that, it would be recorded. Now for somebody who attempts or takes their own life, I believe the way that works is, and I'd have to check with Department of Behavioral Health who works with this epidemiology, I think it would be recorded in their home state of where they're a resident. They do look at numbers of suicides that happen of their residents in state and out of state, but I think that's where it would be. Now military, if they're based here, of course those numbers would be reflected here as well. So that's a great question. Thank you for asking that. Moving on, I think it's important to look at some of the, you know, causes of traumatic brain injury. We've known for a number of years some of the best research. If you look at Simpson and Tate, they did a study in 2002 and then they did a subsequent study in 2007. It's not reflected in this slide, but if you look it up, you'll find they did a couple studies really looking at blast, the etiology of the blast, returning veterans, looking at the highest rate of traumatic brain injury coming from that. Also looking at co-occurring things, depression, post-traumatic stress disorder, alcohol use. When you couple those things together, we'll look at, you know, those signs and symptoms of TBI and suicide. Again, those kind of things are the ones that co-occur. They can, a lot of the research done by Redelmeyer out of Canada and his group, they're really studying those TBIs, and when there's multiple TBIs over the course of a lifespan or in a close proximity to each other, they know that there's an impact on the brain biochemistry. It really, I think, raises the risk for developing a mood disorder, something like depression, anxiety disorders, post-traumatic stress syndrome, those kind of things. And when those things are happening, the risk for suicide really starts going up. And it doesn't mean somebody will attempt or take their life, but it means we need to be more aware and talking openly with somebody. That will really play into, you know, our support for a family member, for a coworker, for a patient who's coming into our care in the community. Again, I think it's interesting, the Redelmeyer study that I told you about at the beginning that said there's a threefold increase in risk for suicide for somebody with a mild traumatic brain injury. Here, Simpson and Tate's work back from over 10 years ago, again, verifies that same thing, 3 to 4 times higher rate when there are TBIs involved. So let's look at risk factors. Many of you have probably had some training, previous education in risk factors for suicide. We'll go through these, won't spend a lot of time on them, but it's important to note because when we look at those risk factors for TBI, there's really a lot of crossover, and being aware of that should kind of raise that red flag that we need to be aware, and that's the things that we'll be talking about. When we look at that, any history, previous suicide attempts or history of suicide in a family, if they've had, thoughts or been treated for it, it doesn't mean that they'll be at that place again, but it raises the awareness that it is quite possible. And so it just becomes part of that ongoing support. We look at the issues they have with alcohol, with current mental illness, any past history of that, their past history if they're a veteran or currently in the military. We know that veterans that are higher rate die by suicide. Current study, if you guys have seen the papers or email, there's the VA just released a really large study where they looked at all the states and they looked at a long history of their veterans. I think it's a total group of 55 million veterans, so you can't get a bigger group than that. That's pretty big when you're looking at a group. They've been saying now, you've probably heard for years, that 22 veterans die a day by suicide, and that was really the current knowledge that we had until this study came out, which lowered that just a little bit, which is good. It's a little lower, but it's still at 20 a day, and that's really high. If you think about the number of Americans who die each day, that's looking at about 1/5 or 1/6 of the total number of people that die each day could be a veteran. So it's, again, raising awareness. Who are those groups at risk? Also among veterans, younger and older, over 50, younger being in that 18 to 29-year-old range. Those are the most at-risk groups where we see the higher percentages and numbers. And some of that study that I'm going to highlight in the next slide really looks at women veterans in the military and post-discharge being at high rates. And those are some numbers that we need to be aware of because it's really information we didn't have. You might have had some anecdotal evidence to that in your own work in the community, but this really validates that and raise awareness so that we can reach out to people. Again, hopelessness and recent loss, looking at their impulsivity, age, I mentioned that, male and female differences, race, you saw the slides earlier on. In Alaska, you have higher rates of among Alaska Natives. But we also have a high rate of Alaska Natives who served in the military. Of course, that does not mean they will be suicidal or have a TBI, but just brings awareness so that we can have those open conversations and really make sure somebody is feeling heard and taken care of. Those are things that are really important. Now, as we look at this next slide, I told you about the VA study coming out. These are numbers that have just come out looking at the rate of female veterans and suicide. The first one there talking about veterans, overall, all ages, dying at a suicide rate of 6 times the rate of non-veteran women. So definitely female veterans at a higher risk. And then I think it's interesting that 18 to 29, the risk of suicide, twice that, 12 times the rate of non-veteran women. When we know, not only in Alaska but the U.S., that 15 to 24, which covers part of that age range, is our highest risk group. You saw those numbers, 2 nationally, number 1 in Alaska. So not, again, I don't want to raise the alarm if I was sitting there and my 21-year-old daughter was, a military veteran and, living in Northwest Alaska. It does not mean they're suicidal, but it does raise awareness. I would want to have that open conversation with somebody if I was the parent or a professional or a coworker, and just letting them know that I would want somebody to do that for me. I think that's important. When you look at that next point coming down, since 2001, the age-adjusted rate of suicide among U.S. veteran females has increased by 85%. I think there's a lot of factors involved there with the number of female veterans serving now in line of duty, but also some of the things that I couldn't bring everything out, but if you read the VA study, there's a higher rate of sexual assault among female veterans that raises, I think, that risk. Some of the things that they're dealing with in terms of being away from family, their supports, those are things I think that we'll consider when we consider helping. We need to be aware of those numbers. If you look at the next one, 40% when they took their life, died by use of a gun. What's important to note is that's a bit higher than what would be among the civilian population. It's right around 30%. So you've got a more trained, capable group of people who've served, know how to use a weapon, which puts them at risk because they know how to do it. So that's important when we're considering, when we talk about safety planning and helping somebody. And then you see the rate per 100,000. Remember I mentioned the rate nationally is 13.4. You're talking almost 3 times the rate of suicide per 100,000 population for women veterans. I think an interesting thing I was talking about with Susan and Pat here as we were getting ready for this webinar is the VA study that just came out looks at men and women veterans who seek support services from the VA, and this is nationally. When that is done for women, 5% of them are at a higher risk for suicide when they are seeking help versus 98% higher risk of suicide for the veteran population of women who do not seek any support services from the VA. For men, it's not as big a disparity, but it's still worth noting. 9% of male veterans who seek VA support are at a higher rate for suicide versus 39% who don't seek VA services are at a higher rate of suicide. So when you look at that, it really shows that veterans who are looking for help and support from the VA in some way, shape, or form are at a much lower rate of risk for suicide. They're getting the help, they're going on to live, they're not attempting, and they're not completing suicide. So we really need to be aware of that because that is, we know it's effective to get help, and that, when we talk about persuading somebody, whether they've had thoughts of suicide but they may be struggling with some traumatic brain injury, to get the help. It's hard when somebody's struggling with depression or post-traumatic stress disorder to want to get out there and get that help. And that's why as a family member, community member, professional, we can provide that support and get them there. And having a team, it's going to be really, really important. So as we look at that, let's look at some of those risk factors, and then we'll kind of compare those jointly between TBI and suicide. So for traumatic brain injury, again, you're looking at that use of substances, issues within the family. One of the things about traumatic brain injury is, you know, increased likelihood for a mood disorder like depression, bipolar disorder, things like that. When that's happening, it's really hard maybe to maintain some of those relationships as that person who's struggling to figure out where they are. So you see how that impacts them. And you can see where family issues could happen, which translates into struggles with holding a job, getting a job, looking like they don't fit in the community, and other things that put them at risk. You know, they're maybe heavy into sports, recreational activities, which we know traumatic brain injuries, we have a high prevalence of those here in Alaska. Whether you go out for the weekend, I was just out this last week caribou hunting with my family. Lots of people, and many of them veterans, out there off of the Denali Highway on their four-wheelers. Accidents happen. And let me tell you, I saw hundreds of men and women on four-wheelers this weekend, and I didn't see any with a helmet on. So just a little side note, it doesn't take anything but a little fall off of that to knock your head. And kind of, I'll tell you, my generation, I grew up in the 70s, and you know, the old thought of, well, you hit your head, you rung your bell, right? Just shake it off, get back in there, get a good night's rest, go back to work, go back to school. That was the thinking. That's how I was raised. So it really takes a concerted effort among us in the community to change that way of thinking. And to do that, we bring awareness about the risk and safety. That's the prevention. And then when injuries do happen, is we get them in for help, get that assessment, find the medical and behavioral health professionals who know about traumatic brain injury. So again, that comes into history, and again, looking at risk, those age groups, older, younger. You know, one of the things that I mentioned at the beginning is when you know something's happened, even though you might not want to, or persuading somebody to go get that exam, making it a part of the medical record. When we have that, it really allows somebody to treat the whole person and be able to provide the most strategic, I think, medical help and behavioral health support. So shared, when we look at TBI and suicide, there's many of these that just cross over. I've mentioned several times the age. With gender, males are, higher prevalence of TBI and suicide, but also knowing that the recent study out of the VA shows that women are not to be excluded in that. They are at an increased risk. And since they did this study, they showed a 85% increased risk. So we can't not look at each gender and then looking at age. Their past history, where they live, you saw the maps showing geographic location, use of substances, and their whole, I think, medical, behavioral health background will have a real impact and a real, if you will, of how that can be looked at. So when those things are going on, you've got those things co-occurring between TBI and suicide. Again, remember I mentioned loss of support in the community, potentially in the job place. So if you're an employer, being aware of these things can make you a better, manager, supervisor when your staff have these backgrounds, and it looks at what we can support them in the workplace. Increased stress, you think about the PTSD, changing roles. When those things have happened to us, whether it's in the theater of war or stateside or civilian life, it changes our life. And so as a parent, as a spouse, a coworker, we have to change some of our supports. And we realize it's going to have a change in brain function. Maybe our ability to recall information, which plays into judgment and impulsivity, decision making. And so we really want to think about how we support somebody. That is all to give you that background so that you can do the best, I think, possible overview when you're looking at assessing somebody for suicide. Really important here, before you can talk about any kind of assessment or safety planning, you really have to know that asking the question is an okay thing to do. And if you look at the research, and here we going on 30 plus years, we have known that if you ask somebody about suicide, you are not going to drive somebody to do it. So those, if you think about some of the strongest myths out there around suicide, that's one of the main ones that we deal with, of all ages and all disciplines, backgrounds, cultures. So really start from that and know that that is how we can get to a basic level of support for somebody. Once we know we can ask the question, the second hardest hurdle we have is actually asking that question. So if you go to any trainings out there, whether it's ASSIST, Safe Talk, QPR, which is question, persuade, and refer, some of the school-based curriculums, signs and symptoms, things like that, they're going to teach you that it's okay to ask the question and then how you ask it. Just asking somebody that you know, have some relationship with, either as a professional or a community member, how you doing? Have you had thoughts of killing yourself, or have you been suicidal? Have you had thoughts, that you would like to disappear or to go away? Those are all kind of things that you talk about when you're looking at somebody who's thinking about suicide. Once you've established that, it's really important what you're trying to get at. Somebody who has struggled with issues of past history, medically speaking, of a traumatic brain injury that they know of or they're not aware of, and thoughts that it's impacted their life. You remember all those risk factors. Somehow they've come to the point where they have a desire to die, some intent is in place, and capability. Those are things that we need to really consider. And so we think about the questions we ask. Why are they thinking about that now? We're asking them why now. With what? You know, how are they thinking about doing this? And have they thought about a time and place? And what is their past? Remember when we talked about if they have a history of suicide attempts or being around it in their family or community? It really lends, you know, I think a higher ability for somebody to be able to do it. And that's why I think military veterans are at a higher risk, because they're trained how to use weapons, and that's what makes them good in the field of war. So they see, you know, violent things, they experience it, they might even be injured themselves. It puts them at a higher risk because they're more capable to follow through. So when you look at that support, we're looking at how do we reverse some of the desire and intent. You know, that's where we really look at who's involved, what are the protective factors or the buffers, who are they connected to, how do they deal with conflict, how can we help those around them, support them through those conflicts, through those issues when they're struggling to figure out what they're doing during the day or what they're going to do tomorrow, and what are some reasons for living. Those are all things that help support somebody. We want this to move towards a real collaborative process. If you are sitting there telling somebody how good their life is or what's going on around them, they're not in a place where they can see that. That's where it's really supportive to just be quiet and listen and gain this information, so that when you talk about reasons for living, they might not see it, but you're taking notes and you're getting that information through that assessment process, which allows you to bring that around full circle to give them some of those resources, which we'll talk about here in a couple slides. But also those third party, the people that are there in the room, whether it's a spouse, a family member, the people at their workplace, other providers that are out there, they're the ones who will work with them, support them, be there for them to prevent them making some of those decisions that maybe put them at risk. In that collaborative process, some key points: being really specific with times and expectations. What are the steps that they're going to take in their safety planning? What are some tangible things? We really want to concentrate and focus on their commitment to life or recommitment. There's a long history in our country of using no suicide contracts. There's really no evidence that those work or have any validity, but there is really good evidence when we make a collaborative safety plan with somebody in their support network that there's real effectiveness there. I'll talk about a study that just came out this last year that shows some of that. Think about the language, you know, some of the things that are going to help lower that risk, and then having tangible things, whether it's just a note card in their wallet, their pocket, using their smartphone technology and iPads and computers to have these things. If I didn't put any slides in here, but there's some excellent apps out there now for smartphones, whether Android, iPad, iPhone, that you can have your safety plan right there at the finger touch. We have an app for our statewide crisis line here in Alaska, which is based in Fairbanks. It's called Care Line, C-A-R-E, Care Line. And with that app, you have the access to, you know, support planning. You have a crisis line to call. You can do some of the texting. The National Veterans Line has 24/7 texting. So there's real resources out there that we can access to provide that help. So to say all that, in your organization, or if you're a community member or a family member, when you're working with them, these are the components. These are the basic components that make up a safety plan. Reduces the risk. Make sure these are in there. What are the warning signs? What are we looking for? That's why I gave you both warning signs for TBI and suicide. You got to be aware of those both. Then what are their past or current coping strategies? What are things that have worked in the past? and we're going to use those. And then we'll talk about maybe some new ones. Who are their supports in the community and with their family? And then we need to take it one more step and look at professionally who is out there. It could just be calling a crisis line. It could just be stopping in at a community health center and talking to a social worker, a case manager. And then that last one is super important. Some of the strongest evidence and research out there shows that if we reduce access to the means like a gun, a knife, medications, alcohol, the keys to a vehicle, whether that's a snow machine, four-wheeler, a car, airplane, we increase the odds that somebody will go on living. When somebody is struggling with the thoughts of suicide, if you look at, a basic model of that, the peak of when somebody's at risk literally is going to be minutes and hours. And that's when that impulsivity can put them at risk if they have easy access to a gun. If they have a hard time getting the means during that period, they can get through that and they could still be at risk for suicide, but they're not at that peak critical moment of impulsivity and thinking. They can go on to live. There's a lot of research that when barriers are in place, the majority of people that are at that point will go on living and never be at that point again, because they've lived through that and they really have that, I think, increased ability to recognize even those warning signs and their coping strategies as an individual, let alone their support network. So let me encourage you, this kind of thing is super encouraging to me to know this level of support is out there. I want to tell you that just recently the Veterans Administration came out with the first study ever done on safety planning. We've never looked at the validity of a safety plan until now, and what they found is that there is an enhanced and increased effectiveness of safety planning and risk reduction when, one, the patients are using their safety plan and somebody, whether it's a professional of some sort and family member, are checking in with them within 24 hours and saying, hey, are you using that? Is it working? That's the first step. The second step is things that aren't working, update it. It's a working model. If something's on there that's not working, they're not using, let's get rid of it, let's replace it, let's make that part of that collaboration. And then the third component of the research showed is that safety plan, are people in their support network, other agencies, other organizations, are they aware of it? Because if everybody's aware, we're working together, that's how we can keep somebody safe. And I think it lowers the stigma and shame that somebody might feel if I walk around and I know I have a safety plan because I've had thoughts of suicide. But if people are saying, hey, Eric, how are you doing? Hey, anything I can do? Hey, let's go out for a coffee, let's go out for dinner tonight, let's go out and walk the dog. Those are the things that I know they know about, and they're supporting me, and that should reassure me through those tough times. So that's a really important part. So if you're a provider out there, let me encourage you, find ways to check in with your patients, with the family members on the effectiveness of those safety plannings. Are they being used? Are they working? And that will increase the effectiveness, and I think that's important. Some of those options out there that work, therapies, medications, groups, do they have belief systems? Do they have things that keep them occupied? Maybe they're, because of their injury, they can't do some of the hobbies they used to do, so we find new ones. There's such a great, vast network out there through the internet, through groups doing different things, whether it's taking care of somebody's, lawn, to going and taking care of an animal, getting out and doing volunteer work. Those are all things that promote somebody being able to deal with their life-changing events that have happened. And also, knowing that somebody has suffered a traumatic brain injury, they're really going to focus on the therapy, of who are they connected with? What are their supports? Because they know, there's different therapies that have shown provenness and effectiveness, but they know that critical component of that is having that support network. If you have people that you're connected to, you see these list of things, something that gives you some purpose, those are the things that offset somebody's intent and their desire to want to die. They could still be capable. If somebody's a trained veteran and they know how to use a weapon, I can't take that away from them, but I can sure work to increase their desire and intent to stay alive, and those are super important. Some of the treatment considerations to follow up on. Remember, if this is part of the medical record, then screening for the causes of other medical behavioral issues down the road will really be important. That second one, I can't emphasize that enough. If you're a medical or behavioral health provider, not only educating the patient but the family, they need to all be educated around issues of suicide, the warning signs, how to support and get them help. Look at asking the question, do they have guns, do they have knives, some of those things that in that impulsivity would be an easy method for them to take their life. You know, having a support network, whether it's somebody who can keep the gun safe for the next week or two, or calling somebody here in Anchorage, I would be calling Anchorage Police Department, and know that they will keep your gun safe for 3 weeks, because they know that the research shows that that's the period of time where somebody could be at a heightened risk if they're going through some life events. Just look at your community. What are the resources around that? This was from the Veterans Administration talking about close monitoring for a year for signs of suicidality. If you look at this study by Redelmeyer, the recent study by the VA, they're showing a number of years to really keep a close tab, just revisiting this. And they showed that 6 years post-traumatic brain injury being the average for when somebody is taking their life by suicide. So knowing that those things can come back up with different life events, and it's just being aware of that and just kind of checking in, being aware of somebody if you see those risk factors, whether they're isolating, not holding a job, family discord, just reminding you of some of those things. And then what can other things that can precipitate for that individual, because we're all different, so it could come across differently. I want to end this and then see if there's any questions that Pat might be getting, but just know that there's resources out there. Here's the Veterans Crisis Line, you know, that's 24/7. They have chat online, they have texting, and there are a lot of resources for this, and they've shown a real effectiveness of this tool being utilized worldwide by veterans and their families. So I think that that is something to be aware of. If you're not aware, here in Anchorage, we have the Chris Kyle Patriot Hospital right here in the middle part of Anchorage, and this is an inpatient service for veterans and current military who are suffering from a psychological illness or from substance abuse or co-occurring, and they will do free assessments, and they will work with you on insurance, whether it's military insurance or private, to get the support and help you need to come in. And that's been open now for, I think, going on 1.5 to 2 years. And so it's a really an opportunity for somebody to get that in patient service here in Alaska without having to leave the state. So I think that's an important service. I mentioned to you earlier our statewide crisis line, Alaska Care Line. There's the number. They have texting at certain times of the day. You can see that there. But the calls 24/7. Confidential is a really good, effective tool to be able to have and support. And there's apps for these to get as well. You see my information. You're welcome to email me if you have questions or if you would like support from our organization in your community. And then just some of the resources that we drew on for this information.
And we do have one question. Are there any other resources out there for older veterans, veterans that may not be good with technology?
Yes, and I think if the biggest thing there, they show that older veterans over the age of 50 are at the highest risk for attempting and thinking about suicide. And so I think getting connected to your local services, whether it's a VA here in Anchorage or a different community of the state, and talking with them about what resources are out there, because we know, first off, the effectiveness of veterans seeking VA services have a lot higher likelihood of getting the help and support they need. But then looking at who their community health center is, a local provider, whether it's a village health aide, all the way up to, you know, police services and just a family physician. And just being real open that not everybody knows all of this. This is a lot of newer information coming out, and it can be, that's where the collaboration between, I think, patient, family, and professionals come together, so they can have that open dialogue and just be able to say, you know, hey, there's information out about this, and what do you think, and, you know, what can we do to support? So that's a great question. You're welcome to email me, and we can talk further about your specific community. Knowing working here with Susan and Pat, we have a lot of opportunities.
We did have also someone ask about sites and applications and apps that you had mentioned. If you are willing to share a list with us, I'll be happy to send that out to all of us.
Yes, absolutely. I'll do that list up and send that to Pat and Susan, and they can make that available to you, because there's really excellent resources out there like that.
I would answer that. This is Susan Maley, and I just want to add on to Eric's good answer about older veterans who may not be comfortable with technology. And the Rural Veterans Health Access Project is, as of September 1st, going to have telebehavioral health available throughout the state to any community where there is a bandwidth for video conferencing. And if there's not a bandwidth for video conferencing, we'll work with those communities and provide information about increasing bandwidth in places that may be an option. So what this means is someone may not be comfortable with technology, but they can, through a computer or their smartphone, have a contact with a secure connection with somebody to talk to who's trained in VA-approved methods of counseling with an agency that we're contracting with that has experience in working with veterans and also rural community members and video conferencing. And all somebody has to do is to be able to click on a link in an email. So it's actually easier than Skyping with your family. So, and then my information's available on the slides too, but I did just want to mention that's for folks of all ages. That's going to be a new resource that's available statewide and has been in the Southeast, and a lot of folks have made use of it and found it was effective, both veterans and non-veterans.
Okay. We have one more question. Tribal organizations are the main treatment agencies for veterans. Can veterans go to their choice of treatment providers, and will the VA pay for the cost incurred? As a non-tribal behavioral health agency, how do we go about working with the VA about this?
I'd like to answer that and also direct you to the VA for information about becoming a choice provider. If you are a non-tribal provider, then becoming a choice provider is the avenue. And if you call the Alaska Veterans Healthcare System, there are choice, what do they call them, ambassadors to talk through how to become a registered provider. And also feel free to give me a call or an email, and I'll put you in touch. I've got the contact information.
Well, Well, this is Eric, and I just want to thank you all for attending today. And know that we're here as a future resource. Susan and Eric and I, you can reach us through website and email, and we would looking forward to partnering with you going forward here across the state of Alaska.
Well, I do want to thank you for attending today, and if you have, we did see a couple of late questions pop up, so those additional questions or any that you come up with later on after the webinar ends, you can email them to us at UAA_AHEC, AHEC, at uaa.alaska.edu, and we'll forward them to Susan and Eric for you for answers. Now, we do wish to thank Susan Maley and Eric Boyer for their presentations and all of you for attending today's event. Your certificates for contact hours from the School of Social Work will be sent in a follow-up email to all participants. If you are viewing as a group, please email us for a sign-in sheet or notate your multiple attendance in the questions box so that we can make sure that you each receive credit. Now, to help us provide the best trainings, please take a moment to complete the evaluation that will appear as soon as the webinar ends. This webinar is now over, and you may disconnect. Thank you very much.